Hi, so this is the section on pulmonary dysfunction. So we're going to kind of work our way down. Well, first we're going to give some definitions, some terminology. Then we'll kind of work our way down through the pleural lining, pleural effusions, pneumothorax, those kinds of things. And then talk about restrictive obstructive pulmonary diseases, including COPD. And then we'll also talk about some infections, tuberculosis, pneumonia, those types of things. So here we go. So if we first just say pulmonary disease, what are the signs and symptoms of pulmonary disease in general? Well, we're talking about breathing. So dyspnea, that's a subjective sensation of uncomfortable breathing. That can be positional, orthopnea, dyspnea when a person is lying down, paroxysmal nocturnal dyspnea, that is going to occur at night. And then hypoventilation, hyperventilation. Hypoventilation when you don't breathe as much, or you don't breathe as deeply, or or your respiratory rate is decreased, you tend to not blow off as much carbon dioxide. And so you have a buildup of carbon dioxide in the blood, which is called hypercapnia. Okay, and so that's increase in carbon dioxide in the blood leads to a decrease in pH. So it's pretty directly related to that. We've talked about that before. A hyperventilation, you could end up with hypocapnia, which would be a decrease in carbon dioxide. Hypoxemia is low blood oxygen. I don't really hear about hyperoxemia, very often because usually we want to maintain a pretty high oxygenation level of our hemoglobin as it is. Cough, acute cough, chronic cough, abnormal sputum, hemoptysis, which is coughing up blood. That can happen, especially if you damage those inner linings. I mean, there are vasculated, structures inside the lung, and when those get infected, they can produce blood just like, anything else. Abnormal breathing patterns. So this is something that you'll probably deal with like an assessment class or something like that. But Kussmaul respirations, deep and labored breathing associated with metabolic acidosis. It's and then Cheyne-Stokes respiration. That's the one where it's an alternation between rapid breathing and then just apnea where it stops completely. Okay. Okay, and then we'll also see cyanosis, which is turning blue, and clubbing of fingers, which we'll look at in the next slide, and then of course pain could also be associated, especially with an injury. All right, so acute respiratory failure. So we're going to talk about acute respiratory failure. The thing to remember about this is really that it's associated with hypercapnia, which remember is increased carbon dioxide levels in the blood, and or it's associated with hypoxemia. So when it really comes down to talking about acute respiratory failure as opposed to something like ARDS, which is a form of respiratory failure, which we'll talk about ARDS, we'll talk about that in a little while. But really the reason we talk about this is because we're trying to figure out if they need ventilatory support or if they just need oxygen. And usually, or oftentimes, it's going to be both. But that's what, when we're discussing acute respiratory failure, that's kind of the focus. Okay, so if we look at hypercapnia, that's increased carbon dioxide, so partial pressure greater than 50 millimeters of mercury, which, as I just mentioned, high carbon dioxide can result in low pH. So remember, as carbon dioxide goes up, pH goes down. Okay, so it's caused by inadequate alveolar ventilation. So that means in our alveoli, we're trying to have an exchange of oxygen and carbon dioxide. And so if you don't have that ventilation taking place, then you can have hypoxemia as well, but you're not going to be able to blow off that carbon dioxide. So we like to say that the air inside there gets stale when you can't get that ventilation, when you can't push the air in, let it swirl around, and then move back out during expiration. Okay, so since that, when you see the increased levels of carbon dioxide, that's generally what's happening, is that you're not getting that air flowing through the alveoli. And so one way to remedy that is to give ventilation support. It can come from decreased nerve firing, so carbon dioxide narcosis could result, disorientation, somnolence, coma can happen just with the increase in CO2, and also decreased muscle contraction. So there we go. Hypercapnia, it's usually associated with inadequate ventilation, so it's going to require ventilatory support. Okay, hypoxemia, again, is low blood oxygen. When you see emia, you should be thinking blood, and of course hypoxemia. That's low blood oxygen, so your partial pressure of oxygen is less than 60, or your pulse ox is going to be less than 90. So it's caused by inadequate exchange of oxygen between the alveoli and the capillaries. So now we're kind of getting away from the ventilatory, even though that could cause so I mean, if you're not breathing, you're not going to have enough oxygen in the blood either. But it's really a focus on perfusion. It's that, is the oxygen making it to, is it making it from the alveolus? So your ventilation, and that's really the key. Your ventilation could be fine, perfect ventilation, but you're not able to get that oxygen. You're not able to do the exchange. So it's kind of a perfusion problem. So it's caused by inadequate exchange of oxygen between the alveoli and the capillary. So in that case, especially if your respiration is good, then you want to increase your O2 levels, and that's going to allow more, there's going to be more oxygen available to move into the capillaries. Okay, so when those things aren't happening, that's when you're going to need some kind of supplemental support, whether it's with hypercapnia, that's going to indicate that you need ventilation support, and hypoxemia is you're going to require supplemental. So if you see both, which is common, then you may need both kinds of support, ventilation and supplemental oxygen. Now, on the previous slide, we mentioned clubbing, and I have a picture over here of clubbing. I just kind of squeezed it in. But clubbing is this, so if we look at hypoxemia down here, we can see the early sign of hypoxemia, not enough oxygen in the blood, restlessness and anxiety, and then a later sign would be cyanosis. Okay, so that's the turning blue. If it's chronic, if this goes on for a really long time, then what happens is, and it shows up in your fingertips, which is interesting, and so it's a cellular metabolic change that will cause your fingers to kind of become bulbous, and well, it's the clubbing. I mean, you can kind of see where this one is kind of more long and drawn out, and then it kind of I don't know if shortens is the right word, but but it becomes more bulbous, okay, at the end. So that's what clubbing is, and it's a direct result of chronic hypoxemia. Okay, so let's also talk about ventilation versus perfusion. So this is one of those things that's kind of important for understanding respiration, because this is something that has to happen. Okay. You have to, you're not only breathing, it's not just important to breathe or ventilation, but it's also important that the air, the gases that you're putting in there, are being exchanged with the blood, okay? And so that exchange of gases with the blood is what's perfusion. We use a Q to represent perfusion, probably because if we used a P, which would make sense, then people would think pressure, but it's not pressure, it's perfusion. Okay, so hypoventilation, so if we're not breathing enough, in whichever way that happens, may lead to hypercapnia or hypoxia. Okay, so which makes sense, okay, because you've got a buildup of carbon dioxide if you're not exchanging it. So that can be caused from depression of the respiratory center, diseases of respiratory nerves, thoracic cage disorders, whatever is reducing your actual physical ventilation. Okay. But what happens is your ventilation perfusion is mismatched. So I'll go ahead and mention this last thing here. Impaired diffusion, if you have impaired diffusion but your ventilation is fine, I mentioned that before with respiratory failure, then you can have hypoxemia but not necessarily hypercapnia. The carbon dioxide that's making it out is leaving, it's going away, but you're not diffusing your oxygen, so you're going to have hypoxemia. Okay, so that can happen with interstitial lung diseases, which is a general term for lung diseases that affect the interstitium. It affects that area around the alveoli. ARDS, acute respiratory distress syndrome, that we'll talk about, pulmonary edema, buildup of fluid, and then pneumonia, which is fluid inside the alveoli themselves. So if we look at this picture here, we can see normally, so this blue capillary, so we're going to assume these are capillaries, it's blue here indicating that it's low on oxygen. Well, as it moves around the alveolus here, so this is the alveolus, or the alveoli, since there are two, as it moves past those, it gets oxygenated. That's what's supposed to happen. But see here, in this next picture over here, you can see that here comes the air and oh, it's blocked. It can't get in there. Your perfusion normally would happen fine, except your ventilation is bad. Okay, so the capillary is there, it's ready to take on oxygen, but there's no air in here. So that's a ventilation problem. So your ventilation is going to be low, and your perfusion is going to predictably be normal, okay, or potentially normal. And then a shunt, so this is a complete blockage. So here we have impaired ventilation, here we have a complete blockage, and yeah, you're not going to have any perfusion that's taking place of that oxygen. Okay, but it's because of ventilation. Now there are instances where there's some kind of impaired perfusion here, so that could be, you know, some kind of tissue damage or a tumor or something like that that's preventing. So here you have a perfectly healthy alveolus, you've got good ventilation, but there's just nowhere the actual circulatory is compromised. So that's what, in this picture anyway, that's what's causing it. It's showing that for whatever reason, even though your alveolus is fine, you're not getting that perfusion. So that means your perfusion is low, but your ventilation is fine. So that's going to be a high VQ. All right, so let's kind of work our way out. We're not going to spend too much time on chest wall disorders. Chest wall restriction, compromised chest wall, deformation, immobilization, obesity. Those are kind of the things that are going to affect the chest wall. There's also something called a flail chest. Flail chest is associated with broken ribs. Usually if you have 2 or 3 broken ribs, then what can happen is you're not containing the lungs the way that they're supposed to be contained, and so they just kind of flail around. I guess that's why we call it a flail chest. But here you can see it kind of flailing around down here on the bottom, and so when you go to inspire, it's going to pull actually on the chest cavity, and if those ribs aren't there to kind of hold that in place, then the lung moves in. Okay, and so that means that air could actually be pulled. If you're squishing the lung, it could actually be pushed to the other side through the branch of the bronchi where the trachea comes down. And then during expiration, then what's going to happen is that this lung's going to expand. There's nothing holding it. It's going to expand, and it's going to pull air from one side, from one lung to the other. Okay, so that's a flail chest. All right, so let's move down through to the pleural lining, and we have this double membrane lining. It's kind of like if you were to take a balloon or something and stick your hand through both parts of the balloon. The balloon's going to have a double lining. I don't know, it works better if you actually see it, but just remember that it's a double lining, and in between that there is fluid. It's called serous fluid that's in between these 2 linings, and that serves pretty much to lubricate it, and so you have a nice, you know, expansion contraction, and that also gives the diaphragm and the ligaments associated with that something to pull on when you breathe in. Okay, so parietal pleural lines. The parietal pleura, parietal is usually associated with the outside as opposed to visceral, which is associated with the organ. So same thing applies here. Parietal is out here, the visceral lining is on the inside, and that space in between has the fluid. So it's, you know, that fluid comes from somewhere, and that somewhere are small capillaries. And so those capillaries are fine as long as they're just allowing that extracellular fluid to move into the pleural cavity, and that's it. That's the way it's supposed to work. But we can get something called an effusion, a pleural effusion, which is going to lead to an increase in the fluid in that pleural cavity. Okay, so that could come from a lot of different sources. Okay, so an infection could cause it, and then some other things that we'll see. So there's this first one, transudative effusion. Okay, transitive effusion, which is too much, which means too much fluid is leaving the capillary. So you can think fluid is transferred from the capillaries into the pleural space. And now, as long as you remember that we're talking about fluid here, okay? So water with some proteins in it to help with the to help it be a little more lubricating, slippery. So so transudative effusion is too much fluid leaving the capillaries. Could be caused by liver failure, nephrotic syndrome, left side heart failure. Well, why is that? Well, remember, these capillaries are providing the fluid. Okay, so the fluid is kind of moving out of the capillaries. Well, if you have liver failure, then you've got a little problem. You're supposed to have proteins in here. Okay, but during liver failure, you're not producing as much albumin, and so you have fewer proteins. And so that's going to, and so you're going to have more or a better chance of fluid moving out because of this lack of protein. So that's going to be an oncotic. You're going to have higher oncotic pressure outside of the capillary, and so fluid's going to move more favorably in that direction, or at the very least, fluid isn't going to be held in the capillary because you don't, I don't know if I can erase that without erasing it all. Nope, there it all goes. But you don't have as many of these proteins. And it's kind of the same thing with nephrotic syndrome. We'll learn about nephrotic syndrome, which is where you urinate out a lot of protein. So a lot of proteins are leaving. So that's kind of what's causing it in that case. Left side heart failure kind of makes sense because you have a backup. So you have congestion that takes place, which is going to increase the hydrostatic pressure. So higher hydrostatic pressure means that it's going to push out. Fluid's going to push out just because of more pressure in there. Okay, but anyway, but at any rate, both of these things are fluid moving from the capillaries into the pleural cavity. Okay, so that's transudative. Exudative or exudative, transudative, yeah, that's it. Transudative, exudative. I don't know why I'm struggling with that word. Exudative effusion is inflammation of pulmonary capillaries. So now, instead of just fluid, we've increased, so exudative, we've got exudate coming out. So we have things that include proteins, other particles, junk is coming out with it. So inflammation of pulmonary capillaries, which increases capillary permeability. So this could be associated with infections, trauma, tumors, and so you have fluid and proteins or particles that are moving from the capillary. So you're going to see more protein in exudative effusion than you are with transudative effusion. Okay, so more protein in pleural fluid than transudative, plus immune cells. So you have, and that's why it's a lot of times associated with an infection. Okay, whereas these are associated with liver failure, nephrotic syndrome, left side heart failure. Okay, so hopefully that kind of makes sense. And then we have some other types of effusion, hemothorax, blood in the pleural cavity due to trauma. Yeah, when you break something, it bleeds, okay? And so in this case, it's bleeding actually into the pleural cavity. Empyema, infected pleural effusion, so pus, so that's when you have a pleural effusion, but now we've got bacteria associated with it, and it's special because it forms pus in the fluid, in that in the pleural cavity. Chylothorax, that's reduced drainage by lymph vessels. Well, you know, if fluid's moving into something, fluid's going to have to leave it, and lymph is always a good soldier when it comes to fluid leaving. But if it gets clogged, then that fluid remains in the pleural cavity. Okay. All right, so let's talk about a pleurisy. Pleurisys are painful. And what that is just an inflammation of the pleura. Okay, so we've got a buildup of fluid. We have inflammation of this pleural lining and probably fluid moving into that area. And so it's common in infectious processes. An audible pleural friction rub may be present. Okay, so things aren't lubricated, things aren't moving the way that they're supposed to. So there's pleural pain, common symptom of pleuritis, usually unilateral, so it's a side that's more affected. Okay, so it's going to be, you're going to feel it on that side. Sudden onset, localized to the lower and lateral parts of the chest, exacerbated by chest movements, deep breathing. Okay, so deep breathing as opposed to something else like if you're having, if you have chest pains and you're not sure if it's an MI, for instance, then if you can take a deep breath or you can change your breathing and there's no pain, then that's more of an indication of an MI or some kind of angina, as opposed to if you do feel pain, then that's an indication that it's pulmonary. It kind of makes sense. Deep breathing, coughing, laughing, that makes sense because if it's pulmonary, those are your lungs, okay? So important to differentiate from other types of pain, musculoskeletal, which tends to be bilateral. So in the case of a pleurisy, it's going to be generally unilateral. Exacerbated, so musculoskeletal could be exacerbated by contraction of the abdominal muscles, which the abdominal muscles are not your diaphragm, those are your abdominal muscles, okay? So that shouldn't be affected if it's pulmonary. Bronchial irritation, substernal and duller rather than sharp, worse with coughing, but not affected, again, by deep breathing. Okay, so this deep breathing thing is kind of an indication that we've got a pleurisy, something with the pleural lining. When it stretches, that's when you're feeling the pain. Okay, so now we're going to talk about pneumothoraxes, and we're going to talk about open tension spontaneous, which open and tension tend to be traumatic, and then spontaneous, you can have primary or secondary spontaneous pneumothoraxes. So let's just go through those. So a pneumothorax in general, pneumo refers to air, okay? So now we have air getting to where it's not supposed to be. You're supposed to have air inside your lungs, inside the alveoli and the bronchial spaces, or the bronchial tracts. You're not supposed to have it on the outside of the lung, okay? So that's what happens with a pneumothorax. And so if we remember that there's always a little bit of negative pressure because that lung, if it's just left alone, that lung is just going to shrink up, right? It's elastic. I mean, that's how you exhale. That's during rested breathing, is the elasticity of the lung will actually pull the diaphragm back up, okay? When it relaxes. So we depend on that elasticity, but that's constantly kind of pulling on that pleural cavity or that pleural lining. And so there's constantly a negative pressure there. Otherwise, if there wasn't a negative pressure, that lung would collapse on its own. More or less. We'll talk about tension pneumothorax. But that's the way it's supposed to be. Otherwise, the elastic properties of the lung would cause it to collapse. So in a pneumothorax, you end up with air, and the air takes up space, which can restrict the lung expansion, and a partial or complete collapse of the lung, and surprise, that's going to affect your respiration if you have a partial or complete collapse of the lung, and that's going to be associated with the pneumothorax. So really, how does the air get there? Well, it's either got to come from the outside your chest, or from inside your lung, because you've got air. Those are the places where air is. Okay, so in a spontaneous, which we'll talk more about, that's coming from inside the lung. An air-filled blister in the lung ruptures, and we'll go through that, primary or secondary. And then traumatic. So traumatic, you've got a couple of choices too. You got stabbed with a knife or something sharp poked through the chest, and you have an open pneumothorax, which means air is going in and out. Okay? Or you have a tension pneumothorax, which means air is going in and it's not going out. So that's going to kind of build up positive pressure inside there. It's actually going to push on the lung. Okay, so let's look at that. Let's look first at the traumatic pneumothorax. So if we think about an opening, Open. And this is the thing to remember. The difference is with an open pneumothorax, it's open. Air is going in during inspiration, it's going out during expiration. Okay, as your diaphragm pulls down on your thoracic cavity, it's going to pull air not just in from your trachea, it's also going to pull it in from the outside because now there's a hole there. But then when it relaxes, when the diaphragm relaxes and the lung recoils, at least your good lung anyway, recoils, it's going to reduce that space, and so the air is just going to move out. Okay, so it's moving in and out. We call that a sucking chest wound. Okay, so air is moving in and out through the wound. However, with a tension, okay, with a tension, it's not really open. It's kind of open because the air is moving in, but the trouble is when the air goes to move back out again, there could be a flap of skin or something working kind of as a one-way valve. That air goes during expiration, you've got, you know, positive pressure, you've got your diaphragm moving up, reducing the size, but it can't escape. Okay, well, that air's in there. It was just pulled in, it's there, so that means it's going to start pushing elsewhere. Okay, and a lot of times it's pushing, it's going to collapse that lung even more, and so that lung's not going to be able to expand with the next inhalation at all. So you can see it's expanded a little bit with an open pneumothorax, but in the case of a tension pneumothorax, it's not going to expand at all. And furthermore, it's going to push on the other side. It's going to push that lung over to the other side, not completely, as you can kind of see in this picture, but it's going to create tension, and that's where our other word comes in. Opens, that's sucking chest wound, in and out. Tension, it's pushing, it's creating tension on the other side, and probably more importantly, it's going to cause compression of the vena cava, okay, which is, you know, your big vein that's going back to the right atrium, impairs venous return to the heart, so now you're affecting the heart and the lung. Okay, and the lung on the other side. So mediastinal shift and tracheal deviation. So the trachea is kind of curving over there to the other side. That's the tension that we need to think about when we try to remember the difference between open and tension. It really comes down to what's happening with the air. Okay, so spontaneous pneumothorax. Well, for whatever reason, you've got well, we know why you have air in your alveoli, but for whatever reason, that air forms a blister. It gets trapped somehow, or it forms an air-filled bleb or blister on the surface, and then when that air can move through, and if that air moves through from the inside now, and it's moving out to this pleural space, well, now you've got air out there. So even though it's not traumatic, it happened, well, it's kind of traumatic, I guess, from the inside, but it's not called traumatic. It's called spontaneous, but that's something that just sort of formed from the inside. So rupture of an air-filled bleb or blister on the surface of the lung, atmospheric air, okay, atmospheric air coming in from the trachea and through the bronchi, enters the pleural cavity because the alveolar pressure is going to be higher than pleural pressure. Pleural pressure is usually negative. And so that means that the air is going to just push right through there. Okay, so air accumulates in the pleural space. Your lung is going to collapse or partially collapse. And it's called spontaneous because it occurs spontaneously without obvious trauma. Okay, so we put that word obvious trauma in, which means you didn't get, you know, stabbed with a, you know, whatever. Okay, so maybe primary or secondary. So how would this happen in a primary sense? I don't really know why it happens. It commonly occurs in tall, thin, young males. It may be associated with smoking, maybe a family history, maybe something called Marfan syndrome, which is I believe it's fibrotic tissue, maybe, I don't know if it's collagen, but I think it is, but Marfan syndrome is where you can't form fibrous material, and so you have weaker membranes. Okay, so which makes sense if you've got some kind of weakened outer coating, then you can have breakthrough. That's where you can form those air blisters. It can just kind of puff out a little bit, and then it kind of moves off into, it ruptures, and then that air has got a free pass to get into the pleural space. Okay. Secondary makes a little more sense. Occurs as a complication of underlying lung disease. So there's some kind of lung disease that is causing, I guess that makes more sense to me because it can cause a weakness in these in the alveoli. There you've got inflammation, you've got damage, something like that. Okay, so that's going to be secondary because it's happening because of a different disease. Okay, which is kind of the definition of secondary. Okay, so clinical manifestations. Well, depends on the size and the integrity of the underlying lung, but it's going to hurt. So ipsilateral chest pain is going to hurt on the side where it's having the effect. Immediate increase in respiratory rate accompanied by dyspnea. So you're going to maybe start to breathe faster, but then you're going to have labored breathing, probably because it hurts, but also because you've kind of messed up the integrity of that nice tight space that's supposed to be there. Tachycardia could result. Maybe because of constriction on the heart. Asymmetry of chest movement, well, that's probably because one of your lungs is partially collapsing. Hyperresonance, so you can hear hyperresonance on percussion. So when you tap on it, then there can be a it's going to sound more hollow because there's air in there on the outside of the lung instead of the lung being pushed up against that. So decreased breath sounds over the area of the pneumothorax because there's less breathing, I suppose, in that area. Hypoxemia, hypotension. Well, you've got so your heart could be having more difficult time beating. Okay, so that could be affected, which could cause the hypotension. But the hypoxemia just kind of makes sense. You've kind of messed with the integrity of your lung all the way around, and so that's going to reduce the amount of oxygen that you can get into your system. Okay, so let's move on to obstructive versus restrictive lung disease. Those are always fun. Restrictive in general means it's harder to get air in. Okay, so something is not allowing either the lung to expand. Somehow your lung, the ability for your lung to expand is restricted. Okay, it's you could say it's not as compliant. So the way you see this is forced expiratory volume in the first second, so or the FEV1. Okay, so FEV1 as opposed to the forced vital capacity of all the air. So the thing to remember is that when you blow through something, that when you're like a respirometer or something like that, that when you breathe out, as long as your lips aren't pursed together, when you have an open way to get the air out, most of your air comes out in the first second. Okay, that's because your airways are so open and they allow that air to just move out very quickly. So most of the air comes out in the first second. Well, if you're having a restrictive lung disease, guess what? Getting air out's not the problem. Getting air in is the problem. Okay, so your FEV1 is probably going to be okay compared to the forced vital capacity of all the air. So it's going to be closer to normal. It's going to be above 0.7. That ratio is, or that, yeah, I guess you can call it a ratio. So what can cause this? Interstitial lung diseases. So the lungs stop being as compliant. Any kind of fibrosis, so something that's causing stiffening that's not allowing them to expand. Lung diseases, environmental toxin, obesity causes it. ARDS, which we'll talk about. Probably should have put that sooner since I keep referring to it. Acute respiratory distress syndrome, which is associated also, I should say, with a lack of surfactant. Lack of surfactant and fluid inside your alveoli is going to not let those expand as much. When you have fluid in the alveoli, that's why we have surfactant, so they can expand. And so when you have too much fluid in there, it's going to not let those expand as much. And so it's going to restrict air from getting in there. Chest wall deformations, decreased compliance again overall. So you're going to hear crackles, decreased lung sounds, shallow breathing. So those are kind of the assessment sounds that you can hear. Obstructive, so that's restrictive. Obstructive is different. It's harder to get the air out. Okay, so that means that your inhalation is okay, but that FEV1, trying to get all that, as much air as you can out in that first second, isn't going to happen as easily. Okay, so you can't push the air out. So that means that ratio is going to be lower. It's going to be less than 0.7. So the amount that you can push out in the first second versus the amount overall, you're not going to get as much out in that first second. Okay, it's going to take you longer to get that air out. Okay, so well, if you can't get the air out, well, this one kind of makes sense then. The lungs tend to be hyperinflated. Okay, so you're kind of going to be breathing at a higher, I don't want to say at a higher level because that doesn't make any sense. But remember, you have this inspiratory reserve volume. Okay, so when you inspire, when you're just breathing tidal volume, you've got the ability to take in a deep breath. Well, what tends to happen is your lungs fill up, so you're kind of working up there in that zone anyway, and so you've got more air in your lungs just because it's harder to push the air out. Okay. And especially because if you think about getting air out, a lot of that does depend on the elastic recoil of the lungs. If you've lost some elasticity, like with COPD, then it's going to be harder to get the air out anyway, not to mention what's going on in your alveoli. So asthma, that's a constriction of the bronchi. COPD, which we'll talk about, includes a couple of things, bronchitis and emphysema. So these are good examples. Bronchius. Yeah. So these are good examples of obstructive, and that's where we get into COPD, which is chronic obstructive pulmonary disease. So it's harder to get the air out. So wheezes, rales, abnormal rattling sound from collected fluid in the alveoli. So that can also be heard. Okay. So let's look at some restrictive lung diseases. Some of these we'll spend a little bit more time on, like atelectasis and atelectasis and ARDS. We'll finally talk about that. But so aspiration, passage of fluid and solid particles into the lungs. Well, if you clog it up, then it's going to be harder to get air in. So that kind of makes sense, not to oversimplify, but that's kind of what we're talking about. So atelectasis, we'll discuss some of these. And then bronchiolitis. Bronchiolitis tends to be pediatric, and it's an inflammatory obstruction of small airways. Okay, so that's what bronchiolitis is. It mostly occurs in children 1 to 2 years old, and it's usually caused by a virus, RSV, respiratory syncytial virus, RSV, is usually what causes that. It can occur in adults with chronic bronchitis associated with a viral infection or with inhalation of toxic gases. But it's just an inflammatory obstruction of the small airways, as opposed to something like bronchitis, which bronchitis can affect the large airways as well. Pulmonary fibrosis, that is the most common restrictive lung disease, and what happens with that is you have excess scar tissue or collagen that builds up in the tissues of the lung, and then that's going to reduce the ability for it to expand. Okay, so that's going to reduce the compliance, which makes sense because we're restricting inhalation. Okay. Other inhalation disorders, toxic gases, coal, asbestos, allergic reactions from inhaled particles or fumes, something like that. So acute lung injury or acute respiratory distress syndrome, we'll discuss that in detail. And then pulmonary edema, we've been talking a lot about pulmonary edema, but we'll hit on that right now. So what is pulmonary edema? Pulmonary edema is fluid moving into the lungs. We discussed that during cardiovascular, and we talked about how when your heart is failing, especially left side failure, then it's going to back up into, and since it's going from the lungs to the left side, if your left side is failing, it's going to back up. It's going to increase the pressure inside your lung. We call that capillary hydrostatic pressure. It's going to actually increase the pressure inside those capillaries of the lung, and that's going to push fluid out, and that's going to lead to pulmonary edema. Injury to the capillary endothelium. So now if we have the capillaries, the pulmonary capillaries that become inflamed, infected, something like that, then that's going to increase their permeability. So we've seen that, we've talked about that before, and that's going to allow more fluid and plasma proteins that are going to move into that interstitial space, and that's also pulmonary edema. Also, the disruption of surfactant produced and surfactant production by the alveoli can also be affected. But we're interested in that pulmonary edema and that fluid moving out. So that's just injury to the capillary endothelium. You've messed with your capillary, so your pressure could be fine. You may not have heart failure, but your capillaries themselves are messed up. And again, we're back here to the lymph vessels on this third one. And if you have blockage of the lymph vessels, something gets in there, an infection could clog them up, or it could be some kind of other damage, then you're not going to be able to remove the fluid from that interstitial space, and so again fluid is going to build up, and that's pulmonary edema. Okay, so all of these things are pulmonary edema. All right, so atelectasis, really this is just a definition. It means that your lung can't expand all the way. Okay, that can come from a lot of different things. We can see here it's just this space occupying lesion. It looks to me like a tumor of some sort, but that's, you know, your lung isn't going to expand in that area because there's something blocking it. It could be air, like with a pleural effusion. It could be fluid like a pleural effusion. It could be air like a pneumothorax, but something is preventing that lung from expanding. It could also just be from inside. There, you know, if you inhale like a piece of popcorn or something, or peanut, I don't know, if you inhale something and it gets into, it blocks one of the branches of the bronchi, well, you're not going to have air moving through there, and that lung isn't going to expand in that area. So that's atelectasis. Okay, it could also just be mucus. Okay, so a thick chunk of mucus could block it too. So airway obstruction, lung compression, increased recoil caused by inadequate pulmonary surfactant. Okay, so if we remember in the alveolus, if you get fluid inside there, remember water tends to be really sticky. I like to think of two pieces of paper. If you have, if paper gets wet, what happens? They all stick together. That's not because of the paper, that's because of the water, and the water is what's sticky. And so the water does the same thing. If you just have water without surfactant, it's going to bead up and it's going to pull on that alveolus, and that alveolus is just going to close in right around it. Okay, so then you're just going to end up with kind of a closed up alveolus, and it's the water that's causing it to kind of close up. Okay, now you're supposed to have surfactant. Okay, and surfactant's kind of like a detergent. It's hydrophilic on one side. One side likes water, the other side doesn't like anything. Okay, so when you have water in there, okay, instead of it beading up, beading with a D, the surfactant's coating it so it can't contact other water. Okay, so that surfactant will stick to the water, yeah, but what it does is it prevents the other side from being able to stick to anything, so it keeps it nice and fluid around here. But when the water builds up so much, or you don't have the surfactant, then it'll pull that closed. Okay, so that's going to decrease the recoil because that it's not going to expand. Okay, so that's going to be an incomplete expansion. Okay, because this thing can't expand because that water's pulling on it so tightly. So compression, atelectasis, it compresses the lung. Okay, so pleural effusion, okay, increase fluid around there. That kind of makes sense. That's going to compress the lung. It's not going to be able to open as much. Cancer is the other example we have here, which you can kind of imagine that this is a cancerous tumor, and that's pushing on the lung. There's also absorption atelectasis, so that's air absorbed from the lung. So we kind of talked about that with like a spontaneous pneumothorax. So that's air that's moving from inside the lung, and it's getting out here, and it's not going to let the lung expand. Okay, so complete obstruction of an airway. Let's see. air absorbed from the lung, or complete obstruction of an airway is followed by the absorption of air from the affected alveoli into the space around the lung and collapse of that portion of the lung. It sounds to me like this is kind of describing a spontaneous pneumothorax. So that's what it sounds like to me. So high risk post-operatively of some kind of damage in the air moving from the lung to that outside space. So clinical manifestations of atelectasis: decreased chest expansion, absence of breath sounds on the affected side. Okay, fever. If it becomes inflamed, okay, so like a bacterial infection or something, then you might see fever associated with it, but that's coming from the inflammation and the infection, not so much from the atelectasis. That's just going to be associated with it. Increased respiratory rate, increased heart rate, okay, because you're going to have less efficient oxygenation. Dyspnea, so difficult breathing. Cyanosis because of hypoxemia, which cyanosis is kind of a sign of hypoxemia. Okay, so that's because your lungs aren't working as efficiently as they should be. Okay, so let's finally talk about acute respiratory distress syndrome, or ARDS. That is fluid buildup in the alveoli. So sometimes we kind of wonder about, we talk about respiratory failure, and sometimes respiratory failure and ARDS are kind of lumped together. It's kind of being the same thing, or acute respiratory failure. But acute respiratory failure, we like to think in terms of ventilation and perfusion. In this case, we're kind of being a little more specific because we're talking about fluid buildup in the alveoli, or pulmonary edema. Okay, so yeah, your perfusion is going to be affected, your ventilation might be affected, but now we're kind of being specific about what's going on with respiratory respiratory distress syndrome. So prevents the alveoli from filling up with enough air. Makes sense. If you have fluid in your alveoli, there's less room for air. Okay. Prevents perfusion of blood moving through the pulmonary capillaries. Yeah, if it has to move through a bunch of fluid, it's going to have a difficult time perfusing those capillaries. So that makes sense too, and it really, again, comes back to this fluid buildup. Occurs in people who already have a lung infection. So this isn't a disease. ARDS isn't a disease. It's kind of a manifestation of a disease. Okay, and it's one that we don't want to see. Okay, so you can have pneumonia, you can have some kind of an infection, but you don't want to see it kind of deteriorate to ARDS. You don't want to see that the inflammatory response kind of take over the lungs. Okay, that's not as good. That's not a good thing. So acute lung injury like pneumonia, aspiration, sepsis can trigger that inflammatory response via capillaries and direct alveolar damage. And then you can see kind of in this picture where it fills up with neon green fluid in the picture anyway. But you can also see how that fluid is kind of pulling that capillary shut. So exudate enters the alveoli, makes inhalation more difficult. Inflammatory cells and mediators result in release of proteolytic enzymes. Okay, so now we've got the inflammatory process that's kind of in overdrive in these alveoli. So it releases proteolytic enzymes. Proteolytic enzymes are there to kind of, they're there to kind of inhibit some other offender, like a bacteria or something like that. So fibrous protein production can then also ensue. So proteolytic enzymes can damage your actual tissue of the alveolus. Fibrous protein production, that would be part of the healing process, I suppose. But somehow you're producing fibrous proteins. It's causing a decrease in lung compliance, and that's going to last. Okay, so that's kind of an important thing to remember with ARDS, is that it's this, you're going through the entire inflammatory process, which also is going to turn on fibroblasts, and it's going to, initiate the healing process, which is usually a good thing when something is broken or cut. But in this case, you're laying down fibrous tissue, and that's going to reduce the compliance. Okay, so you're not going to be able to. It's going to last even after the The ARDS is gone. It damages these type 2 alveolar cells, which is going to limit surfactant production. So that's going to pull those alveoli closed, and it's not going to be able to expand as much. And what do we call it when we don't have, if we have incomplete lung expansion? Atelectasis. So atelectasis is going to result, and that again is because of this lack of surfactant. Okay. Pathogenesis, acute lung injury, alveolar injury. This left side kind of moves us through what happens when we don't have surfactant production. Okay, and the right side kind of takes us through that inflammatory process. It's ultimately going to lead to increased permeability and edema, or that buildup in fluid. Okay, so we see treatment is difficult, but may involve mechanical ventilation to increase your PEEP, which is positive in expiratory pressure. That's great. Okay, so if you've got fluid in the alveoli, you're not getting good exchange. Then if you can increase that end expiratory pressure, then you can kind of expand that a little bit, and you can recover some of that ability of that perfusion to take place. You increase that partial pressure inside there, but too much, you can pop it. So you can cause trauma to it, so barotrauma. So if you increase that pressure too much, then you can actually just cause damage in that way. So it has to be pretty carefully calibrated. And then I've also seen limit fluids, which kind of makes sense because you've got a buildup of fluid. So that could also be applied. Okay, so let's talk about bronchial asthma. Chronic inflammatory airway disease. So we're trying to pick apart things that make things different. Spasm of smooth muscle of small bronchial airways resulting in obstruction. So now we have a spasm of smooth muscle, okay, small bronchial airways, and an increase in mucus production. Okay. Okay, and it doesn't have to be associated with an infection. Okay, so that's going to be different, but it does affect those small bronchial airways, and you can see here these airways that have smooth muscle associated with them. So that's one of the hallmarks of asthma is smooth muscle constriction, which is important for treatment because we take something like a beta adrenergic receptor agonist, and which is essentially mimicking what your fight or flight would do to your bronchi, your smooth muscle in the bronchi, and it's going to cause it to open. I mean, when you're in a fight or flight situation, those things relax and it lets more air move through. Okay, so releasing that spasm or that contraction of those smooth muscles is kind of key, but it's also an indicator of what the disease itself is, or the condition, asthma. And then also there's going to be increased mucus production. So what causes it? That also has something to do with it. Exaggerated hypersensitivity response to a variety of stimuli. So now we're talking about kind of a type 1 hypersensitivity. Okay, so remember talking about that. So manifests more on exhalation, causing excess clogging with mucus and wheezing. This is an important point when it comes to asthma and COPD and any kind of obstructive disease. It's going to manifest more on exhalation. You can't get the air out. You also have the clogging with mucus that can kind of get in the way of pushing the air out of those alveoli. Inhalation can also be affected because you're blocking these bronchial airways, but in general it's going to be that difficulty pushing air out. Okay, so you've got an ability to kind of use your diaphragm more sternly to pull air in, but getting it out is going to be problematic. Okay, so recurrent episodes of airway obstruction categorized by wheezing. This is what asthma is in general. Breathlessness, chest tightness, and a cough that is often worse at night and early in the morning. So there are two types. Atopic. Generally, I think of atopic as something that's not contacting it directly. It's not actually causing the damage. It's doing it sort of in a systemic way. And really, when I think of atopic, I think of hypersensitivity, I think of allergies. Okay, so, and that's the case with asthma. Type 1 hypersensitivity involves that IgE mechanism. Remember, where the IgE are kind of sticking out of these mast cells, and then that's going to cause a chain reaction type of response. There's also irritant mediated or non-atopic. So that can be a number of things. Chemicals, cold are listed here. I've got some others listed in other places. So how does this happen, this mechanism of early and late phase bronchospasm? Well, early, the first 10 to 20 minutes, that's going to be that IgE triggered release of chemical mediators, okay, from mast cells. That's going to directly lead to a histamine response, and that's going to cause some of this bronchospasm. Results in rapid activation of smooth muscle and bronchospasm, which is what I just said. So that's going to be the early 10 to 20 minutes. But then we kind of get recruitment of white blood cells, lymphocytes, eosinophils. Eosinophils can cause some damage. They've got these. They can cause breakdown like trypsin. They have proteases that break down proteins, which is not so good. But those are recruited. They trigger the release of chemical mediators such as leukotrienes. Leukotrienes are kind of related to prostaglandins. They're kind of made in that same arachidonic acid pathway. Arachidonic acid, and then you kind of have the leukotrienes, which are made, and you also have prostaglandins that are made. And so they kind of work in that cell-mediated fashion. So it can take a while to get those up and running sometimes, but it's part of that bigger process, which is why it's they can be associated also with the early, but they're definitely associated with this late phase and the recruitment of the white blood cells. Edema can occur. Okay, so you've got this buildup of exudate in there, or fluid moving out. Epithelial damage via eosinophils may result. So that's not so good. That's when asthma is really causing some damage beyond just difficulty breathing. Okay, so so let's look at these again. So atopic antigen triggers activation of mast cells. Okay, so you've got your antigen that moves in here, and then activation of the mast cells. So we covered that in type 1 hypersensitivity. But then the inflammatory response will involve other white blood cells. I know I just said all this, and mediators, but either way it leads to bronchoconstriction and mucus production. Okay, and that's going to be obstructive exhalation, more difficulty expiring. So other non-atopic triggers or irritants, respiratory infections can do this, epithelial damage, exercise, hyperventilation, cold air. These are also reported to cause this bronchospasm. Inhaled irritants for some people, inflammation, vagal reflex, which is part of your rest and digest. It's more of a rebound mechanism, your vagus nerve. Aspirin and other NSAIDs can also cause it in some cases. Abnormal arachidonic acid metabolism. Remember, that's how those leukotrienes were made. Okay, so these are just some other non-atopic or irritant associated triggers for asthma. So clinical features of asthma, bronchial asthma: decreased peak expiratory flow rate. Again, expiration. You're not able to push the air out. So fall in PEF, peak expiratory flow, to levels below 50% of what's predicted when in a healthy person, or when the person is not having an asthma attack. So less than 50% during an acute asthma attack indicates severe exacerbation, need for emergency intervention. Okay, so that's a large reduction in that case. Other clinical features: hyperinflation, well, because you can't exhale. Prolonged expiration secondary to air trapping. Dyspnea, difficulty breathing. Fatigue due to increased work of breathing. Hypoxemia, hypercapnia. Again, you're not getting that exchange of gases in the lungs. Distant breath sounds, expiratory wheezing. Pulsus paradoxus can also occur. We saw that with cardiac tamponade. So fall of systolic blood pressure during inspiration due to increased negative intrapleural pressure caused by air trapping. Okay, so that's going to press on that too. That's not a big clinical feature when I think of asthma though. Okay, so severe asthma, severe prolonged asthma that's refractory to conventional methods of therapy, highest risk in persons with history of previous exacerbations resulting in respiratory failure, respiratory acidosis, and the need for intubation. So if this has happened before and it continues to happen, then we call it severe, prolonged, doesn't work with normal treatment, and this does occur, and so I guess it makes sense that we would consider it to be severe if normal treatments aren't working. So and there's also, it's just going to be a rapid deterioration during an asthma attack. So this is someone that it can be very, very serious, happens frequently, and they deteriorate rapidly. Okay, so let's talk about some other obstructive pulmonary disorders besides asthma, and we're going to talk about chronic obstructive pulmonary disorder. COPD, fourth leading cause of death in the US and globally. So, what is COPD? An airflow limitation that is usually progressive and associated with enhanced chronic inflammatory response in the airways and the lung to noxious particles or gas. Okay, it's an airflow limitation, and to really understand what COPD is, we need to talk about the little subunits of COPD, which really come down to emphysema and chronic bronchitis. Okay, so its fourth leading cause, as I mentioned, it's preventable. Tobacco smoke. Smokers tend to, by and large, be the people who get COPD. Now, it can happen from occupational dusts, asbestos, those kinds of things can also lead to COPD. Harsh work environments are also associated with it, especially, back in the old-timey days, back when there wasn't as much regulation for work environment. That could cause damage as well. Other indoor and outdoor pollutants. Now there's also, usually this occurs in people over 60, or over 50 at least, but there's also a genetic form, which is a mutation, excuse me, COPD. It's a mutation in something called the alpha-1 antitrypsin gene. So I'll say more about this, but one response to some kind of an irritant is the production of trypsin. Trypsin is a protease that can break things down. So neutrophils can release it, but it's a protease that cuts up proteins. Okay. Well, that's supposed to be stopped by something called antitrypsin, because if it's not stopped, then it can actually cause damage to the alveoli. And so a gene mutation in something called the alpha-1 antitrypsin gene means that when this protease is activated, this trypsin is activated, then there's nothing to really limit its damage, and so it's going to cause damage more. So let's look at the different parts of COPD as a whole, and that's going to be emphysema, which is enlargement of airspace and destruction of lung tissue. Emphysema is more associated with the alveoli. And chronic bronchitis, which is increased mucus production, obstruction of small airways, and chronic cough. And surprise, it's more associated with the bronchi. Okay. There's also something called bronchiectasis, which is an uncommon type of COPD. Infection and inflammation destroy smooth muscle in the airways, causing permanent dilation. Okay, but we're going to focus on these two, emphysema and chronic bronchitis. So emphysema. What is emphysema? Well, it's part of this COPD heading of COPD. And the important thing to remember about emphysema is that it is associated with this destruction of alveolar walls. Okay, and that's what you really need to be thinking about. It's destruction of alveolar walls. It's permanent enlargement of the gas exchange airways. So whereas maybe your alveoli, that's where gas exchange takes place, maybe looked like that before, and it could, you know, kind of look like that after. Now this one on the right here, which is healthy, is going to have better surface area. It's going to be more elastic. Okay, but then when this damage takes place, this is just a big sack. Okay, in there, it's not going to have the ability for air exchange as much. It's going to lose its elasticity, and that's really what we're talking about with emphysema. So two causes: smoking, and then so neutrophils in the alveoli secrete trypsin, so that's what I was mentioning, and increased neutrophil numbers can happen due to smoking, and so you're going to have an increase in that trypsin, which is going to cause the damage. And then this hereditary, this alpha-1 antitrypsin, hereditary form is where the alpha-1 antitrypsin isn't made. So because the alpha-1 antitrypsin is supposed to inactivate that trypsin before it can damage it, but in the case of the hereditary version, it doesn't because it's not there. In the case of smoking, it's producing too much, which can cause damage. Okay, so ultimately damage to the elastic fibers, the elastin, which is a protein. So damage to the elastic fibers of the lung increases the compliance. So now you have a lung that's more than happy to expand. It's very compliant, but it's lost the elasticity. It just pushes right open, and then it's not going to bounce back the way that the lung is supposed to do. So it's very easy to fill the lungs, but it's difficult to get rid of trapped air. And what happens with trapped air? Trapped air, you have stale air, quote unquote, but that's going to increase carbon dioxide. Okay, so you're going to have higher carbon dioxide levels. Yes, you're also going to have compromised oxygenation, okay, associated with that too. That makes sense. You've sort of reduce that surface area. Okay, so enlargement of air spaces, but damage to that alveolar sac wall and the capillary beds. Okay, so that's your emphysema. Other pathological mechanisms, so inflammation and fibrosis of small bronchial airways. So now we can kind of look down here. So this is the alveolus, but here are your small bronchial walls. So that's going to, they're going to lose their efficiency overall, and that can obstruct flow. Hypertrophied mucus glands, so excess mucus can be produced, which is going to obstruct airflow. And importantly, loss of these elastic fibers. Okay, so this is what you see. You see the elastic fibers are supposed to be causing that recoil to take place after it's stretched, but those are broken down, and so the lung doesn't recoil as much. It becomes more difficult to exhale, to get air out. So airway collapse, obstructed exhalation, and air trapping. Okay, so this is what you see. You see normally air moves in, and then air is supposed to move back out, but you've got this mucus being produced here. You've got a compromised small airway, and so when the air tries to move back out, it's not able to, and it can get trapped. Okay, so the other part of COPD, bronchitis, chronic bronchitis. So what is chronic bronchitis in general? Hypersecretion of mucus and chronic productive cough for at least 3 months of the year for at least 2 consecutive years. So that's the definition I got. You might see a different definition somewhere else, but that's what this book said. So we can go with that. But what it is it's bronchitis that's chronic. Okay, so it's bronchitis that shows up, lasts a while, and keeps continuing to come up. So that's chronic bronchitis, and that is associated. It's really hard with COPD when someone is diagnosed with COPD to really separate out the emphysema from the chronic bronchitis because they kind of happen together. So an airway obstruction of major and small airway. So now we have obstruction of major airways as well. Hypersecretion of thick mucus in the large airways, increased mucus secreting goblet cells in the small airways, so there's just mucus, a lot of mucus, which is going to lead to that productive cough. Fibrosis of the bronchial wall can happen. Clearance is often reduced due to impaired ciliary function, probably from smoking or something like that, some kind of metaplasia that's taking place, which is reducing ciliary function. So not only are you producing more mucus, but it's harder to get that mucus up, and that's going to result in hyperinflation of alveoli, so you can't get the air out. Okay. So some treatments, bronchodilators, expectorants, chest physical therapy can be used to treat it. Expectorants may be contraindicated if it's also associated with emphysema, but that's a physician decision there. Okay, so sometimes we refer to pink puffers and blue bloaters. It's just another way to kind of remember this. Pink puffers is usually emphysema. You're pink because you are able to maintain oxygen levels, but you have to really work at it. Okay, so proportional loss of ventilation and perfusion increase respiration to maintain oxygen levels. So dyspnea, okay, so difficulty labored breathing, increased ventilatory effort, use accessory muscles, pursed-lipped breathing. So one of the big problems with emphysema in general, as its own kind of thing, is that you're not able to push air out. And so that means you're using accessory muscles, pursed lips, you're trying to create some pressure in there because your lungs are just like expanding, whatever, we'll take the air. And so pushing it back out is the problem. And that's going to increase some of that pressure in there inside the lungs too, the partial pressure of the gases, which is going to help with the perfusion. So a lot of times blowing out will actually, that increase in pressure can actually help. But it takes a lot of effort to do it. So that's why you have the puffing, okay? The pink puffers. And then the blue bloaters, which is associated with bronchitis, that's a case where you can't increase your respiration enough to maintain oxygen levels because your bronchi are blocked. Okay, so if you have one of these things like emphysema occurring by itself, then you may not have the blocked airways. You just can't get the air out. So you can increase the effort and do that. In the case of bronchitis, you can't. I mean, that's going to be restricted, or I shouldn't say restricted because it's obstructed. So levels because of these blocked bronchi. So you can see cyanosis. That's why it's called blue. Polycythemia, increased hematocrit due to overproduction of red blood cells. Your body's trying to recover, but you're also going to have this expanded kind of trapped air in the alveoli. Okay, so that's the bloating, I suppose. Cor pulmonale is an enlargement of the right side of the heart due to lung disease. Okay, so we saw that as maybe right ventricular hypertrophy, but it has a name when it's associated with lung disease, and so that's cor pulmonale. Okay, so COPD. Again, you can see that if we look at COPD, tobacco smoke is the big one. Okay, so that is the big cause of it. So you can see inflammation that takes place, and then that inflammation, we don't want to go through that inflammation process again, but that inflammation can actually lead to increased protease activity, which is going to lead to your emphysema, or continuous bronchi irritation and inflammation, which can lead to the chronic bronchitis. And both of those things together can lead to the airway obstruction, air trapping, loss of surface area, that's going to be, your emphysema side, frequent exacerbations. Yeah, I mean, especially if you get chronic bronchitis and you're already having a hard time getting perfusion to take place, getting that gas exchange inside, you've got the hypercapnia going on, and then the chronic bronchitis can really hit you hard if you're a COPD patient. But all of these things also, dyspnea, cough, hypoxemia, hypercapnia, and then the expanded right ventricle, the cor pulmonale. Now, the inherited form, antitrypsin, that's not necessarily going to be associated with bronchitis, okay? That's just the that assault on the alveoli of the lung the alveoli of the lung, and that's going to cause that damage. So it's going to pretty exclusively, the inherited form is pretty exclusively going to be associated with emphysema. Okay, so now we can see here a picture of the classic tripod position and pursed lip breathing of a patient. Okay, so let's talk about some infections. Gosh, this is going on forever. I apologize. But we're getting it all in one section. I don't know if that's better or not. So respiratory tract infections, acute bronchitis. Earlier we were talking about chronic. Now we're talking about acute. It's an acute infection or inflammation of the airways or bronchi, commonly follows a viral illness. Okay, virus. It's an infection. Okay, and it's acute. Comes on fast, kind of runs its course maybe a little more quickly, and it's not supposed to come back like it does with chronic bronchitis. So acute bronchitis causes symptoms similar to those of pneumonia, which we're getting ready to talk about. Okay, so if somebody has chronic bronchitis or they have pneumonia, how do you know? What's the difference? Well, the difference is that with chronic bronchitis, it's inflammation of the airways. Okay, the airways or the bronchi. Pneumonia is going to be buildup of fluid in the alveoli. So now again we have the alveoli affected. Bronchitis is supposed to be pretty specific to the airways. Okay, so acute bronchitis symptoms similar to those of pneumonia, but does not demonstrate pulmonary consolidation, so you're not going to have that fluid buildup, and chest infiltrates, which are, you know, the white blood cells moving in, blood, other things in addition to the fluid. Okay, so let's talk about pneumonia. It's a lower respiratory tract infection. And as I already mentioned, the infection takes place in the alveoli and it's associated with excess fluid. So this is excess fluid buildup in the alveoli. And of course, if you have fluid in the alveoli, it's going to take up airspace. Now, pneumonia has a number of different causes. It's not just a thing. It's excess fluid building up. It's infection with excess fluid building up in the alveoli. That's what pneumonia is. But it can be caused by bacteria, virus, fungi, protozoa, parasites. Really, you know, especially with fungus, a fungus, that's more opportunistic. That's somebody who has a compromised immune system. That's generally when that takes place. HIV, AIDS, sometimes that can happen in that case, or any other kind of immunodeficiency. Now, pneumococcal, which is streptococcal pneumoniae, is a bacteria, and that is considered the most lethal. Okay, and it causes an intense inflammatory response. So this one, it's not going to kill everybody, but it can be much more serious, and it can cause death. There are also viral forms. Most cases of pneumonia, in fact, are preceded by some kind of a viral upper respiratory tract infection. So you have an upper respiratory tract infection, and sometimes that's what we talk about. We worry about it settling in the lungs. Okay, and that's what happens is that when it settles in the lungs, quote unquote, we're talking about excess fluid buildup in the alveoli, taking up airspace. Okay, so that's when pneumonia can move down, or the illness can move down and affect the alveoli, building up that fluid, which I keep saying. All right, so different bacteria. It's kind of important to know the type of bacteria because then you can know the type of treatment. But different bacteria are associated with where the pneumonia was acquired, and specifically, and this is probably one you should remember, is that healthcare acquired or hospital acquired is most commonly streptococcal pneumonia, also the one we were calling pneumococcal. Okay, so that's normally what's going to happen when you acquire this in the hospital. That's the strain that you're going to see more often. And it can be antibiotic resistant, of course, because there are so many antibiotics, especially in a hospital setting, and some of these patients receive a lot of antibiotics that this particular strain has figured out a way to survive that. Community acquired can be a lot of different ones: Pseudomonas, Staph aureus, Enterobacter, E. coli, Klebsiella. I was going to not say that, but there you go. And so community acquired can be a number of them. Causative microorganism influences the clinical presentation. Okay, so how it presents. Now here's a flow chart that takes us through it, but I like this one better. It's kind of the same thing, just broken up a little bit more. So the onset of pneumonia, signs of systemic inflammation. Okay, malaise, chills, fever. You have an infection. You have a systemic inflammatory response, which is what these are. Okay, chills, especially fever. So infection, inflammation, and you're going to start producing serous exudate, because remember, this is pneumonia. We have fluid building up in the alveoli, which is going to cause some congestion, feelings of congestion, and a productive cough because of that fluid, and you can cough that out, hopefully. But then it can progress, and you can start to get damage to the alveoli and to those small capillaries leading to it. And then you can start to see blood-tinged sputum. So you might see, you know, kind of a pink sputum. Can happen. You can. There's pain, pleuritic pain, and you can feel that from the damage inside. So that's another thing to kind of remember, that pneumonia a lot of times has that productive cough. It can be blood tinged. Plus you've got the inflammatory feelings, and you've got pain in the chest. Okay, and so that's kind of an indication that we might be dealing with pneumonia rather than just a cold or something. Now, that's from the serous exudate that was initially being formed, and now it's turning into fibrous exudate that may have some blood in it, blood cells. So white blood cells are going to move in. They're going to try to fix the problem, and white blood cells, as they kind of form and die, they can sort of form a grayish color, gray hepatinization. So if the white blood cells overcome the infection, then the white blood cells are going to denature the hemoglobin, which is going to cause that gray color, and they destroy fibrous. But the problem is the white blood cells destroy fibrous proteins and liquefy exudate. It's reabsorbed into circulation. Well, I guess that's not the problem. The problem would be the damage to the actual alveoli, and that can lead to, a lot of people who have had pneumonia will have that permanent damage, that permanent scar tissue that takes place, and it's kind of just always there. But what this is talking about, the white blood cells are kind of getting rid of all of these things, liquefying it, and then reabsorbing it, and that's going to be part of your resolution. Okay, so now let's talk about TB, tuberculosis. Mycobacterium tuberculosis hominis. It's a type of mycobacterium which produces mycolic acid, which makes it kind of waxy and hard to kill, and that's part of the problem. It is the single infectious agent responsible for the most deaths worldwide. 26% of avoidable deaths in developing country are from tuberculosis. So it's a problem, and it's a problem we would like to maybe get a better handle on. There are a lot of drug-resistant forms. I'm reading about them on a regular basis. Some drug-resistant forms are now becoming resistant to our last line of defense to treat them. So it's aerobic. It thrives in O2-rich environments. Makes sense why it's in the lungs. Okay, so forms a waxy capsule, very resistant to destruction. But this is part of the testing of it. It causes these bacteria to retain red dye when treated with acid and then acid-fast staining. That's that mycolic acid that's going to hold the stain in and cause it to turn red. At least that's the way it works in my head. Evokes a typical type 4 cell-mediated hypersensitivity. So you that's why we can do a skin test for it, because these T cells are kind of moving around, and those can respond to it. Equals chronic inflammation, tissue destruction. Cytotoxic T cells aren't known for their friendliness, really, unless they're fighting on your side, but sometimes they can turn and they can actually do some damage. So transmission, how is it transmitted? Inhalation of airborne droplets. Okay, somebody coughs on you. that has TB, and then you inhale it, and it's already in your lungs, and that's a great place for it to get started. So droplets from infected persons, crowded and confined living conditions can kind of lead to that. So what can happen is that, so the way that this works is you get the bacteria can infect, okay, and then your immune system will try to fight it off. So macrophages start a cell-mediated kind of immune response. They kind of go in and they try to control it. They try to, you know, take out this bacteria, but they have a difficult time. And a granuloma forms, something called a granuloma or a Ghosn focus. And that granuloma is an attempt to wall it off. It's trying to kill it. It's trying to get rid of it. But instead, all it does is it forms a something called caseous necrosis, which are, you know, dead macrophages. T cells are trying to kill it as well, and they're inactivating, and they do an okay job, but they do form these granulomas. Okay, it's caseous necrosis, this walled off thing, and so your immune system can get control of it if you're, you know, immunologically healthy, or, you know, presumably. But you do produce this thing called a Ghosn focus. Okay, it's a granulomatous formation. It contains the macrophages T cells, and it also has some inactive TB bacteria. Notice I'm not saying dead bacteria. It's inactive, which means that it can kind of survive in these granulomas in a latent form. Okay, so that's latent tuberculosis, and so the tuberculosis is still there, but it's not growing, it's not dividing, it's not active. Okay, so it's not making the person sick. The person doesn't have any symptoms. They can't spread it because it's isolated, which is your immune system's best attempt. However, it can become active again. So it can advance again to active TB, which is why we worry about latent tuberculosis. So latent TB cannot be spread from person to person, but can advance. The active disease, of course, can spread. It is active, and it does make the person feel sick. Okay. TB diagnosis takes 3 to 6 weeks to develop a positive TB test. What does that mean? That means that when you are infected, so if you're infected on a Tuesday, the 1st of whatever the month, that means it's going to be the end of the month or the next month before you can even be tested for it. So you can be sick for a month before you can be tested and show a positive TB test. Okay, so usually that's not a problem. You might know that you're sick. Now there are different ways to test. TB skin test, purified protein derivatives. So these are, I guess, isolated proteins specific to the tuberculosis bacteria. And remember that type 4 hypersensitivity, those T cells, so you can kind of prick the skin, get under the skin there a little bit, put some of these this protein derivative, these proteins in there, and then just wait and see. Wait and see if the immune system says, oh, I've seen that before. Okay, I know what that is. And then they'll cause a type 4 hypersensitivity. And so you're going to have that redness, swelling. I don't know, I think of things like poison ivy lesions or something like that. I've never had a positive one, so I don't know if they itch, but that's what's going to take place. You're going to see a reaction. Measures that delayed hypersensitivity that follows exposure. If it's negative, you're considered not exposed. If it's positive, that means you were exposed at some point, and which allowed that cell-mediated immune response to be active. So other ways to test for TB, radiographic studies, though that's where you're going to identify those Ghosn lesions, okay, or cavities, I think that's supposed to say, and that can be, the cavities can be there if it's active. You might be able to see the lesions, the tuberculosis lesions, if it's not active. So sputum culture and acid fast stain. Well, sputum culture if it's active and you have the bacteria that are kind of moving out into the sputum, then yeah, you can kind of cough up a chunk of that, and then you can stain it and you can find out if there's the mycobacteria present. Okay, but that's really kind of going to be more of a diagnosis for an active infection. Okay. All right, so that's TB. The last slide here is pulmonary embolism. It's part of this. We've already talked about pulmonary embolism, what an embolism is. It's a clot that forms in one place and then ends up somewhere else. Well, the place that it ends up a lot, as we know, is in the lungs, especially if it's from the lower body, especially if it's from the periphery, actually anywhere in the periphery, because it goes back to the heart as vessels are getting bigger, and then it moves through the right side of the heart to go to the lungs, and all of a sudden those arteries get smaller and smaller, form into those capillaries or arterioles, and then can cause a clot. Okay, so it's a bloodborne substance, lodges in a branch of the pulmonary artery. So one of the branches of the pulmonary artery obstructs the flow. So it's a thrombus. If it's in the blood, air embolus can also happen. So air can also cause a blockage. Fat embolus from bone marrow post-fracture, that can cause an embolus as well. So DVT, deep vein thrombosis, is the most common source of pulmonary emboli. Signs and symptoms: chest pain, difficult labored breathing, dyspnea, tachypnea, which is going to be rapid breathing. Okay, so those are all the symptoms. Wow, this was really long.